Hello, I'm Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, I'm going to be discussing ankylosing spondylitis. But just as a general reminder, axial spondyloarthritis is classified as spondyloarthropathy. Now, the spondyloarthropathies, including psoriatic arthritis, enteropathic arthritis, and reactive arthritis, are a heterogeneous group of conditions with overlapping clinical manifestations and an association with the gene HLA-B27. Axial spondyloarthritis is a chronic progressive inflammatory arthropathy, which can ultimately lead to radiographical changes in the spine and sacroiliac joints. Now, it's this radiographical stage that's known as ankylosing spondylitis. So, ankylosing spondylitis, or AS, as I'll call it through this podcast, is a chronic, immune-mediated inflammatory disorder that predominantly targets the axial skeleton, especially the spine and sacroiliac joints. Now, this condition evolves insidiously, often beginning in young adulthood, and gradually imposes limitations on spinal mobility with age, eventually leading to fusion in advanced cases. But beyond its skeletal manifestations, AS can also extend its reach to various extra-articular organs, and this emphasizes the systemic nature of this disease. Now, it's calculated that the global prevalence of AS ranges from 9 to 30 people per 10,000 of the general population. And epidemiologically, AS typically presents before the age of 40, with the majority of affected individuals experiencing their initial symptoms during their late teens to early 30s. And the onset after the age of 45 is very uncommon in my experience. Males are disproportionately affected compared to females by about 2 to 1, and a significant familial component has been recognized, and there's a strong genetic component in the risk of developing AS with a heritability of 97%. And as we mentioned before, one of the most well-established genetic associations is with the human leukocyte antigen HLA-B27. And this is present in about 90% of patients who have AS, although somewhat surprisingly, the HLA-B27 contribution to the total genetic risk for AS is relatively modest, at around the 20% mark. Perhaps more surprisingly still is the fact that the role of HLA-B27 in the pathogenesis of AS still remains largely unclear. So if we look at the underlying pathophysiology of AS, this involves chronic inflammation at sites where ligaments, tendons, and joint capsules attach to bone, and these regions are referred to as entheses. And this process, known as enthesitis, is absolutely central to the disease mechanism, and it distinguishes AS from many other forms of inflammatory arthritis. Now, clinically, the hallmark of AS is persistent back pain that demonstrates inflammatory characteristics. And this type of back pain typically begins insidiously in people under the age of 40. It tends to improve with physical activity and with non-steroidal analgesia, but it fails to respond to rest. Morning stiffness that lasts more than 30 minutes and nocturnal pain that disturbs sleep but which improves upon getting out of bed are also common features. Now, over time, progressive spinal rigidity can then lead to postural deformities such as hyperkyphosis. Peripheral musculoskeletal symptoms may also accompany axial involvement in my experience, and patients often report hip and buttock pain and peripheral arthritis that commonly affects the lower extremities. If the digits are involved, known as dactylitis or sometimes even sausage digits, and inflammation of tendon insertions are present, these further reinforce the diagnosis. Now, unfortunately, AS isn't confined just to the musculoskeletal system because it may involve various other organs, often complicating its initial clinical presentation. And among the most frequent extra-articular manifestations that I've seen is anterior uveitis, which can affect as many as a third of patients with AS, and which can present as unilateral eye pain, redness, and photophobia. The gut may also be involved with inflammatory bowel disease, and psoriasis, although less common, is another notable association. Unfortunately, the systemic inflammation with AS has been linked to an increased risk of cardiovascular morbidity and mortality, and this includes a higher prevalence of atherosclerosis, as well as specific cardiac abnormalities such as aortic regurgitation. Now, although pulmonary involvement is less frequent, this does remain clinically important since reduced chest wall expansion because of costovertebral joint involvement can lead to a restrictive pattern on pulmonary function testing, and in advanced disease, pulmonary fibrosis may develop. Neurological complications are rare but serious, and these can include things like cauda equina syndrome and atlantoaxial subluxation, both of which carry significant morbidity. Spinal fractures, and I'm thinking particularly of vertebral fragility fractures here, are also more common in AS due to altered biomechanics and chronic inflammation that then compromises bone quality. So if we're looking at diagnosing AS, this requires a combination of clinical, laboratory, and imaging findings, but it's important to point out there is no specific test purely for AS. So a thorough history and examination are vital here, particularly to differentiate AS from other causes of chronic back pain. So the identification of inflammatory back pain is absolutely essential. So just as a further reminder here, we need to look for at least 2 of these 5 points when we're diagnosing down this type of back pain. So 1, early morning back stiffness. 2, improvement of back stiffness with exercise. 3, resolution of symptoms using nonsteroidals. 4, alternating buttock pain. And 5, waking in the second half of the night with back pain. Now, in the presence of this symptomatology, we should also screen for a history of psoriasis, uveitis, and any gut complaint suggestive of inflammatory bowel disease. Unfortunately, on average, there's a delay of about 8 years between the onset of symptoms and a confirmed diagnosis in most AS patients, often leading to a worse clinical outcome. And you have to say that is a salutary point. Laboratory tests aren't definitive, as I say, but they can support the diagnosis. So inflammatory markers, ESR and CRP, are elevated in the majority of active cases, but they may remain normal in a substantial subset. Testing for HLA-B27 can provide supportive evidence, especially in equivocal cases, but we should not be using this in isolation to confirm or exclude the diagnosis. Imaging studies play a key role here in both the diagnosis of AS and disease monitoring, and plain radiographs remain the initial modality of choice. One of the key radiological findings here is sacroiliitis, with a standardized grading scale ranging from 0, which is normal, to 4, which is complete ankylosis. In the early stages of AS, radiographs may show subtle subchondral erosions and sclerosis, but as the disease progresses, joint space narrowing and eventual fusion may occur. Now, in the spine, we may get squaring of vertebral bodies and syndesmophyte formations, contributing to what's known as the bamboo spine appearance on X-ray in advanced cases. If radiographs are inconclusive, then MRI scanning is useful for detecting early inflammatory changes, such as bone marrow edema, which we don't normally see on X-rays. So just to pull this together before we look at treatment, we've got the diagnostic clinical criteria of low back pain, which is present for more than 3 months. It's improved by exercise, but it's not relieved by rest. We've got limitation of lumbar spine motion in both the sagittal and frontal planes. And we may have limitation of chest expansion relative to normal values for age and sex. And then we have the radiological criteria of sacroiliitis on X-ray. Now, I always believe that it's definite AS as a diagnosis if the radiological criterion is present, plus at least one clinical criterion, and probable AS if 3 clinical criteria are present alone, or if the radiological criterion is present but without any clinical criteria. Now, if we look at the management of AS, this focuses on alleviating the symptoms in our patient, preserving functional capacity, and preventing long-term structural damage. But our ability to predict the likely disease course of AS in a patient does remain limited, unfortunately. So treatment approaches, as you might expect, include both pharmacological and non-pharmacological strategies, and non-steroidals remain the first-line pharmacological agents here, particularly in the early and moderate stages of the disease. They provide symptomatic relief, and they may slow disease progression when used continuously rather than intermittently. If we have a patient where non-steroidals don't control their symptoms sufficiently, then I would always consider a slow release preparation, especially if morning stiffness is the main concern for the patient. And obviously you can add additional pain relief, such as simple analgesics or even amitriptyline, especially if there's poor sleep due to pain. Local corticosteroid injections are useful occasionally for symptomatic sacroiliitis, peripheral enthesitis, and arthritis. But it's a really important point to say here. Oral steroids are not recommended in AS due to their limited efficacy in axial disease. And we should always be referring to a rheumatologist for confirmation of the diagnosis and when considering additional therapy. Now, these are typically biologics. So tumor necrosis factor inhibitors, TNFIs, such as adalimumab, etanercept, and infliximab, have shown substantial efficacy in reducing inflammation and improving the quality of life of our AS patients. Now, the current NICE advice is that these are options for treating severe active AS in adults whose disease has responded inadequately to or who can't tolerate non-steroidals. The response to these drugs should always be assessed 12 weeks after the start of treatment, and it's only if there's clear evidence of response that these treatments should be continued. Treatment with a different TNF inhibitor is recommended for people who can't tolerate or whose disease hasn't responded to treatment with the first TNF inhibitor, or whose disease has stopped responding after an initial response. We may also consider interleukin-17 inhibitors in patients who are unresponsive to TNF-Is or in those with coexisting psoriasis. And now finally we also have Janus kinase inhibitors, and these can be considered for patients with AS who are unresponsive or who have contradictions to both TNF-Is and interleukin-17 inhibitors. Now, although ankylosing spondylitis is a lifelong condition, many patients with it do maintain a reasonable level of function and continue to lead active lives. Now, the rate of disease progression and the severity of any complications do vary hugely, but as a general point, I would say that many patients who do well are those who lead active lifestyles and have the discipline to maintain a daily exercise program. Early diagnosis and aggressive treatments do have the potential to slow structural damage and improve patient long-term outcomes, but those with early onset disease, persistent high disease activity, or significant extra-articular involvement do face greater functional impairment and an elevated risk of comorbidities. Unfortunately, if left untreated, AS can cause significant spinal deformities, with around a third of patients eventually suffering from some degree of thoracolumbar kyphosis. And corrective osteotomy and stabilization are recommended here under certain conditions, and I'm thinking of things like severe kyphosis or advanced hip arthritis. As we've touched on before, cardiovascular disease is not only a major complication, but the leading cause of death in patients with AS. Just briefly looking at non-pharmacological interventions, these are integral to comprehensive care and physical therapy, with an emphasis on spinal mobility, posture, and respiratory exercises, all of which can significantly improve outcomes in AS patients. And so rehabilitation does play a vital role in long-term management here. Multidisciplinary approaches incorporating rheumatologists, physical therapists, and other specialists can address the broad spectrum of disease manifestations, and respiratory therapy can become particularly important in individuals with reduced chest expansion or pulmonary complications. We sometimes forget we should strongly encourage smoking cessation, not only for general health benefits, but to reduce the risk of pulmonary fibrosis and cardiovascular disease in our AS patients. Group exercise programs and hydrotherapy have also demonstrated particular benefit in symptom control and functional improvement, and patient education remains a vital cornerstone of management, as anyone with AS should understand the chronic nature of their disease and the vital importance of adherence to both pharmacological treatment and lifestyle modifications. So that was a quick general review of ankylosing spondylitis, and I do hope you found it to be of help the next time you see a patient with this often disabling condition. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments, or even ideas for future podcasts. We genuinely do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.